Hi there, I'm Ilyaas, and today, along with my colleagues Quratul-Ain Parket and Kauthar Salie in fifth year, we'll be educating you about the classification and management of open fractures. Open fractures and their management classification are crucial skills needed by medical professionals in the South African setting, as trauma forms an incredible part of our burden of health, and open fractures occur mostly from trauma. We'll therefore be giving a quick guide as how to effectively classify and manage open fractures safely and effectively. Here's a clinical scenario often seen in our setting. JP is a 22-year-old professional rugby player. While walking home from practice one day, he was bumped over by a car whose driver was distracted by their cell phone. The driver of the car frantically called emergency services, who swiftly arrived at the scene. JP sustained an open fracture of the tibia, and this is what it looked like.
Before we discuss the classification and management of an open fracture, let's first define what an open fracture is. An open fracture is a fracture with direct communication to the outside environment. Essentially, this means that the broken bone manages to cut through the skin. Therefore, both the bone and the soft tissues are highly likely to be contaminated by foreign material. This introduces a very high risk of infection in open fractures. Common sites for open fractures include the tibia, this is the most common, the ankle, the phalanges, the metacarpals, and the forearm.
The fracture is then classified according to the Gustello-Anderson classification. This classification looks at the extent of contamination, soft tissue coverage, and the presence of vascular injury. There are 5 categories in the Gustello-Anderson classification. Type 1 is a wound that is less than 1 centimeter with minimal contamination or muscle damage. Type 2 is a wound between 1 and 10 centimeters with moderate soft tissue damage. Type 3A is usually a wound that is more than 10 centimeters due to high energy impact and it has extensive soft tissue damage. It's also contaminated, but there is adequate tissue for a flap coverage. Type 3B is extensive periosteal stripping. The wound then requires soft tissue coverage. Type 3C is vascular injury that requires vascular repair regardless of the degree of soft tissue injury. With the information we now know about the classification of open fractures, we can now classify JP's fracture as a class 3A.
The management of open fractures starts with basic ABCDEs, as the patient's life is of critical importance. All these things need to be seen to, and the patient must be stabilized before focused management may take place. JP was stabilized and taken straight to Groote Hospital. Once the patient is stabilized, it is very important to administer antibiotics. Early antibiotics and analgesia are given based on the grading of the fracture, as discussed earlier. Grade 1 and 2, you will give a narrow spectrum antibiotic, namely cefazolin, for 48 hours. For grade 3, you will give a broad spectrum antibiotic, usually a coamoxiclav, cefazolin, gentamicin, plus metronidazole in the case of a farmyard injury, for 5 days. Tetanus toxoid, 0.5 milliliters, is also given subcutaneously.
All open fractures should be irrigated and dressed to reduce infection and as preparation for theatre. Remember that the solution to pollution is dilution. This means that the wound should therefore be cleaned with brief irrigation and sterile saline dressing should be applied. After irrigation and dressing, the neurovascular status should be checked. So don't forget to test the surrounding nerves and palpate the patient's pulses. Thereafter, the wound should be reduced and immobilized to reduce further soft tissue injury. And lastly, the patient should be referred to an orthopedic surgeon for further surgical management. Theatre management includes debridement of the wound, whereby all foreign matter and loose bits of bone which have no soft tissue attachment should be removed. Thereafter, a thorough washout of the wound must be done using at least 5 liters of warm normal saline. The fracture is then stabilized through external fixation. The wound should not be sutured closed, but rather closed with a suction dressing and should be re-looked at in 48 hours again.
Open fractures make up a large part of the burden of disease in our clinical setting, and knowledge on how to manage them is crucial. Often, it is the simple forms of management that improve outcomes for patients. Therefore, it is important to remember the basics when it comes to open fractures. Classify it, administer analgesia and antibiotics. And remember, the solution to pollution is dilution, so irrigate and dress the wound. Then assess for neurovascular status, reduce and immobilize, and then refer.